Prostate cancer is the #1 solid cancer in men. 200,000 men a year are diagnosed with it, but fortunately less than 30,000 die from it. So although it's a very common cancer in men, it's not the most deadly. It falls behind lung and colon as the third, sometimes second leading cause of cancer death. That's approximately the same incidence of women that die of breast cancer, so it's still a significant disease. Recently, there's been much controversy over PSA screening. The United States Preventative Task Force suggests that it should not be used as a screening method for prostate cancer. That causes quite a bit of a problem in that it's the only test we have to screen with, and we know the limitations of PSA. We don't want to go back to the era where we didn't screen with PSA because the mortality was very high then, and often when prostate cancer was found, it was too late. What we recommend now is to use more than just the number of the PSA. We look at other risk factors, how old the gentleman is, how likely with family history he'd be at risk. If they're African American, these are all risk factors. So we gather all the risk factors and then have an intelligent discussion with the patient, saying that you do have some risk factors for prostate cancer and perhaps we do wish to do a PSA. If we find an elevated PSA, if we find a rising PSA, it means look closer because it could be prostate cancer. When it's rising or when it's elevated, it may be only 1 out of 5 chance that it is prostate cancer, but that's a 20% chance. And if there's family history or African American, it's even a higher chance that it's prostate cancer doing that. And so its role should be just to make us look further. If we find prostate cancer, we know we don't necessarily have to treat it, but we don't want to miss that 15% of men who it could be a life-threatening disease. Screening is effective, PSA is effective. When you look at the main reason for PSA is to make us look further. That's the job of the PSA. It's not to diagnose cancer, it's not to diagnose enlarged prostate, it's to make us look further, and that's its main job. Although the majority of our patients, 85%, have a very indolent or slow-growing form of prostate cancer that probably doesn't require treatment, there is 15% with a very aggressive form. If you remember, 200,000 people a year are diagnosed with it, and 30,000 still die from it. Well, we want to stop that 30,000. We want to find that aggressive cancer and treat it. Currently, when we diagnose prostate cancer, the majority of those patients really don't need treatment, and the majority of them undergo what we call active surveillance. With active surveillance, we monitor them every 6 months to a year. We watch their PSAs. Sometimes we repeat the biopsy to make sure it's not getting worse, but it's with the full expectation that it'll be probably over 20 years before it may bother them. As a group of urologists here, on a daily basis, we see patients that have elevated PSA, and that was the only reason we diagnosed their prostate cancer. Many of those patients went on to get treatment and be cured and are alive today because of PSA screening.